Hello, everyone. How are you? Good morning, good afternoon, good evening, wherever you are around the world. I'm very happy to be here today with Dr. Broumand. Thank you for your present. Thank you for your presence today, Doctor.
Thank you for having me.
I'd like to introduce you for our audience. Dr. Broumand graduated from the University of Florida College of Dentistry in 1997 and subsequently from the University of Miami School of Medicine in 2000. He completed his postdoctoral residency training in oral and maxillofacial surgery along with an additional year of general surgery at University of Miami Jackson Memorial Hospital in 2003. Since then, he also completed a fellowship in head and neck tumor and reconstructive surgery under the mentorship of Dr. Robert Mart at the University of Miami in 2005. Upon completion of fellowship, he served as assistant professor of clinical surgery in the University of Miami's School of Medicine Division of Oral and Maxillofacial Surgery in Miami, Florida from 2005 to 2006 and was private practice from 2006 to 2012 until his full-time return to University of Miami School of Medicine Division of Oral and Maxillofacial Surgery. Most recently, he served as a full-time associate professor in the University of Miami, remains as adjunct clinical assistant professor at the University of Florida College of Dentistry, Department of Oral and Maxillofacial Surgery since 2010. Uh, that's a huge bio. I was talking to him before our meeting. His bio is so extensive, and then uh, I think that Dr. Brown, if he wants to talk more about it, it would be amazing because he has a lot of to add in our in our Porgenor. Thank you for your presence today, and Dr. Brown, the floor is yours.
Well, thank you for having me. Um, it's great to be here. Thanks for the introduction. It was very nice of you. And I love being here. It's great Saturday. It's a beautiful Saturday. It's great to do some more virtual learning together. And it was great talking to you beforehand. It's nice to be talking to you. Like I said, I was just recently in Brazil. I know you're an oral surgeon in Brazil, and I was just recently there in your beautiful country. I was in Sao Paulo teaching a zygomatic implant course to some fellow oral surgeons and general dentists, and they were all from the U.S. and Canada. And I didn't get a chance to go to Rio, where you're from. I was in Sao Paulo. It was
Maybe
beautiful.
next
I loved
time.
it. Yes, next time. There was no COVID yet. It was before COVID. It was right in February, a couple of weeks before COVID hit, of course, Brazil and the US, and it was terrible. But I'm hoping for things to go back to normal. I don't know what normal is
Yeah.
anymore. This is the new normal. And so instead of seeing each other in person, we're going to do and that virtual learning. So today we were going to talk about zygomatic implants. And I think zygomatic implants are just one of the things that I've had in my practice for about, I would say, 16, 17 years. They've been around for, since obviously with Dr. Branamore, 1989. They first started working with them. When I first started doing zygomatic implants, it wasn't for reconstruction of the severely atrophic maxilla. It was for reconstruction of maxillectomy defects, what they were designed to do. Then as time has gone on, I think more people are using for reconstruction of the maxilla. And like you
Yeah.
and I were just having a discussion, you prefer doing a big bone graft and reconstructing a maxilla. And I love the technique. I love doing big bone grafts as well. But what's happened is a lot of patients want immediate satisfaction. Like yesterday, I had
Mhm.
a patient, very nice young man, only 48 years old, and he went down to Cancun to do some destination medical tourism. So he paid a lot of money for an upper and lower all on four, and the upper and lower all on four failed miserably. So now he's got a massive defect in the maxilla with loss of soft tissue, and same thing in the mandible. Those are really difficult because you have to do block bone grafting or Lefort
Yeah,
osteotomies, and then you have to do, soft tissue grafting as well. So for patients like that, zygomatic implants are great because you can return them to form and function immediately because you could do immediate load. But he's still a candidate for reconstruction as well. In my hands, I've had zygomatic implants that I have at least 15-year follow up on, and
awesome.
most of them have done very well. The success rate for zygomatic implants is anywhere. I just finished writing a chapter on quadruple zygomatic implants, but
Mhm.
I was reading a lot beforehand, and I realized there's so much in the literature on zygomatic implants. At the same token, there's something to be said about reconstructing a maxilla back to its normal form and function with bone grafting. But we live in a society where everyone wants immediate gratification. They don't want to go without wearing a denture for a while, and they don't want to go without teeth. So, with zygomatic implants, it's like an all on four. We can place the implants and load it the same day. But, a lot of patients
Yeah,
um, still choose the old route. And I think it's important to keep in mind that that is an option as well. But when you're doing that, when you're doing a big block graft and reconstructing the entire maxilla, it's something that has to be done in the hospital most of the times.
yeah, for sure.
And it can't be done really by anyone but an oral maxillofacial surgeon because it's done in the hospital and it's a big surgery.
Yeah.
So with zygomatic implants, as you know, there are more and more surgeons doing them. I remember when I first started doing them um, in 2003, I was told by my rep that there was only 180 surgeons in the U.S. that did zygomatic implants. Back then, they were very, very careful on who they were training. Now, I would say that there's at least 3 to 4 times that number. There's at least 1,000, um, uh, you know, oral surgeons, periodontists, and general dentists in the country that place zygomatic implants, and that
Mhm.
same thing worldwide. So there's a lot more people that are doing them. Obviously, with the new extramaxillary technique, there's less morbidity. It's easier to do. There's less complications.
Yeah, for sure.
Nonetheless, you can still have complications,
Yeah,
but it's become more common.
I think that's my concern about Zygomatic implants. Uh, in our hands, we know the question about the complications, and then we know how can we handle it. But when we try to teach for another doctor, sometimes they can try to place the zygomatic implant, and then if they have some complication, sometimes they need to send to us. They need to send to oral maxillofacial surgeon to fix it, and then that's my. I think that's my unique concern about it.
Sure. No, I listen. I when I do my courses, so I do I would say 5 or 6 zygomatic courses a year, and I encourage the attendees, even the ones that are oral surgeons. I said, first come to my hands-on course where you're working on a cadaver, and we teach the course on cadavers first, on human cadavers, not a pig. A lot of people do courses on, you could do dental implants on on a pig or a cow. Those are fine for regular implants, but for zygomatic implants, because the orbit's right there, the infratemporal fossa is there, you have to do it on
Hmm.
human cadaver. So we encourage that, and after that, I encourage them to come watch me do a live surgery where I'm doing the surgery and performing it on someone, and they just watch. And then the third time, I encourage them to come to my office where we get them a license. Or when I go to Brazil, like I was mentioning, when I go to Brazil, I'm able to get them a temporary license where they actually get to place the implants under my guidance on a patient. And even then, I tell them not to just jump into it, um, to do the easy cases first. Do a single zygomatic implant, not a quad zygoma. And
No,
it
for
takes
sure.
time. I
Right.
remember The first couple that I did, I was very nervous, and even now, sometimes when I do a difficult case, I try to keep in mind that things can go wrong. So you always have to be aware of that.
Yeah, for sure. And they need to have a like something like a curve of knowledge. They need to understand better
Sure,
and start with simple case to to a hard one. And
sure,
then I think that's you are totally right. And as you told, uh, my preference is the reconstruction, and I know that sometimes the patient can have some problems in the post-op. That's normal. And then, what do you think about this complication when you compare the complication from the bone reconstruction, for example, from the hip to the zygomatic implants?
Oh, that's a
What
great topic. I was
do you
going to
think about
cover
it?
that in my lecture and my
Oh,
talk.
awesome.
So I have that in there. But obviously, as you know, when you do a hip graft, if you're doing an anterior hip, there's problems with walking. There's problems with
Yeah,
disturbances in walking, pain, sometimes nerve
sometimes 3
damage.
months.
Which, yeah, I mean, especially with the anterior hip, and most oral surgeons are trained to do the anterior hip, and not as many do the posterior hip. When I was in my training, we did a lot of posterior hips and a lot of anterior hips. So in my
Hmm.
sorry, in my training, we did a lot of them. But nowadays, most people aren't trained to do them. So it's almost as difficult. I work with the residents here at the University of Arizona. And a few weeks ago, a few months ago, I did a tibia bone graft in my office.
Hmm.
And the chief resident came and a senior resident that had never seen one before. Whereas in my training, we did them every week. I have done so many posterior and so many anterior hips, and nowadays it's just so rare for that to be done. I mean, most surgeons are not able to do that. So anything you do, if you don't do enough of it, you're going to have more complications. And obviously, the more of any procedure you do, you're going to deal with complications throughout your career. But with zygomatic implants, there are complications, and I have them in my presentation. So once I start presenting that, I'll show you some of the complications that
Awesome.
I've had to deal with.
Awesome. I think that's very important for our audience to understand all of
Oh,
the
absolutely.
not only the good things from the zygomatic implant, but they need to understand the about the complications too. I think that's a very good for all of us.
Oh, sure. So let me if you want, I can get started on our presentation soon. Should I
Okay.
start with that?
Yeah, for sure. The floor is yours.
All right, let's do that now. So I have this now. There we go. And there we go. So let me do full screen. Give me 1 second here. I'll go full screen. Perfect. Now, how are we doing? Do you guys see it well? All right, so I was going to talk
Yes.
about reconstruction of the severely atrophic maxilla with zygomatic dental implants and go over some pitfalls and some things that can go wrong and some things that are um, um, some required for you to be aware of. Here's one of my courses that we did. Here you can see there's two skulls. I have this is a day when people came to my office and I had them practice doing zygomatic implants on a plastic skull bone first, and then they came and watched me do it on a patient. So that's important because you need to practice to be aware of the anatomy. A knowledge of the anatomy is absolutely important. Now, Carlos, this is a what you like to do and what I love to do as well. So this is a completely atrophic maxilla, and we took a hip graft and you can see we shaped it to deform the maxilla. We did a beautiful block grafting with some particulate bone. And the only problem with this, obviously, as I mentioned, is you have to take bone from the hip, which is a second surgical site, and you have to go back later, remove these screws to place the implants. But more importantly, you have to do a vestibuloplasty because there's not as much Soft tissue. There's not a lot of connective tissue here. This patient has lost their teeth over years and years, and with the loss of soft tissue and bone, they become a victim of edentulosum, and now they're basically a dental cripple. So in order to help them, you can either go the route of zygomatic implants, or like you and I were mentioning, you reconstruct the maxilla. So this is how we did it the old days, where we did a big block graft and later went back and did implants. Well, with the evolution of angled implants and graftless solutions, this has become less common, and a lot of oral surgeons don't even do this anymore. This is another variation which I did, where someone that had an atrophic maxilla, we would take a block of hip and shape it like a maxilla and screw it in with dental implants. The problem is sometimes you would put too much pressure on that bone, you'd get dehiscence. Then you would have a dental implant that was partially in the maxilla and partially nothing around it but granulation tissue. And of course, then there was the evolution of zygomatic implants, we can see here. So we've come a long way. But how did all this start? First, we had pterygoid implants, then we had long implants, zygomatic, and then we had tilted implants, which now everyone is a master of. Everyone does it. But let's keep in mind there are different ways to do everything. So, a lot of people do conventional all on fours, and they do them all over the world. And, I do some of these. I don't get a lot of all on fours because my practice is mostly dealing with complications of all on fours. And as you know, there are quite a few complications. So you can perform a conventional all on four when someone has bone present in zones 1 and 2 of the maxilla bilaterally. So that's anteriorly in the premaxilla and then in the buttress region on canine eminence. But if sometimes there's no bone in zone 3, and that's fine, then you tilt the implant. But if there's no bone in zone 2 or 3, then you really can't do a conventional all on four. A lot of people do implants if there's only bone in zone 1 and try to do an all on four, and that's when these things fail invariably. And I've seen a lot of patients. So this patient that I was just mentioning that came from Cancun had had a regular all on four done, but there was only bone in zone 1, nothing in zone 2 or 3, and as a result, the all on four failed. So that's something to be aware of. Now, zygomatic implants are indicated in an edentulous maxilla when you only have bone in zone 1, but some people try to do an all on four, as I mentioned. So if you have some bone in one side on zone 2 or a 3, you could still do a zygomatic on the other side. Now, what I like to do is at least try to do one implant anteriorly, because sometimes with zygomatic implants, you get some rocking of your restoration if you only have the zygos, because of there's a long lever arm, and these are long implants, so you can get a little rocking of the restoration. But if you can't get in an anterior implant, you just rely on the 4 zygomatic implants, and you stabilize them through cross-arch stabilization, and generally we have great results. So the long implants, these zygomatic implants, were first obviously came into play and designed by Professor Brandmark in 1987. And they became clinically more available in 89. And there have been multiple surgeons that have made variations. There's a Zaga classification, there's the slot technique, and now there's the intramaxillary and extramaxillary techniques. So there's multiple variations. Nonetheless, they're all very similar. They take advantage of that dense zygomatic bone, and it's a graftless solution for severe resorption in the maxillary bone with an immediate load protocol. So in my hands, the zygomatic bones have done so much better when they are loaded immediately. If I put an implant in and we don't load it right away, in my experience, the success rate is lower. But the original zygomatic implant was straight. Now, there was variations that came into play with an angled head. Then you would use an abutment to correct the angulation. And then now there's back to straight ones again. So here's the traditional intramaxillary technique. The way this worked is the implant pierced the oral mucosa in the second premolar region from a palatal position. It passed through the sinus mucosa, through the sinus along the lateral wall of the maxilla, while we try to preserve the sinus mucosa. So we've all placed zygomatic implants and pierced the sinus mucosa. Unfortunately, it's more common than people like to admit. You try to avoid it, but if that happens, you don't abort the procedure. It's not like a sinus lift because you're not doing a bone graft. However, we always try to avoid the sinus mucosa. I make a big window, push the sinus mucosa out of the way, and depending on the contour of the lateral maxillary wall, sometimes a portion of the implant passes lateral to the sinus and is actually um, sticking out of the sinus antrum. So just keep that in mind that that can happen as well, where not the entire implant is inside the sinus into intramaxillary technique. So the tip of the implant enters the base of the zygoma and travels through the zygoma and pierces laterally. So a lot of times nowadays with Anatomage and Vivo and all these software and Nobel Clinician and I think now DTX, you can plan these ahead of time so you see the trajectory of your implant and make sure it's parallel to the zygomatic buttress, but you want to make sure that when you put on the abutments, they emerge in an ideal position in the mouth. But the bottom line is you provide a patient with a fixed provisional prosthesis right after surgery. So, and you're doing this based on multicultural anchorage. Multi-cortical anchorage. And, some of these implants have an aggressive thread pitch at the apex. Some of them don't. Now, most of the implants are becoming more and more aggressive at the apex. So that way you get much higher primary stability. And we've gone through many, many changes amongst Dr. Brandmark's disciples. And of course, the implant that he designed originally now has changed in so many ways. It went from an external hex to now there's an internal connection. So just keep in mind, whatever technique you're using, make sure you stick to one manufacturer and do it well. Here, they looked at the initial study that they did for Dr. Brandmark's initial pilot group. It was a 10-year follow-up. It was done in 2000, published, at a 95% success rate. So that's very good. But keep in mind, some of these implants do fail. And in their hands, the ones that failed were more common early. A couple failed late. I have seen some failures myself. When they fail early, it's often a surgical failure. When they fail late, it's often a restorative failure. So keep in mind that just like any kind of dental implants, you'll have restorative and surgical failures. Indications are for, in my hands, initially, I try to do them only for severe atrophy of the maxilla or for failed all-on-fours. Some people now do it for moderate atrophy, and unfortunately, I'm seeing some cases where patients hardly have any atrophy and they do zygomatic implants just because they're so common and popular to do now. So you have to keep in mind, you have to do these for the right patient and the right indication. So what's better, intramaxillary versus extramaxillary? Well, it depends. So in my hands, I do both, and I have found that for the more resorbed maxilla, the extramaxillary works better for me. But more popular now is the extramaxillary technique because it is easier. The dissection is not as delicate, and the technique is more forgiving. But keep in mind that there is no better technique. Multiple people have the intramaxillary technique is true and tested, and for years that's what everyone advocated. And then we tried doing the extramaxillary technique because there were some complications with the intramaxillary technique, and I'll go over those at the end of this presentation. So people have developed the extramaxillary technique, but just keep in mind that that one is not without complications either. So things can go wrong with either technique. So here I'm going to show you a couple of cases. Here's a patient came in for a failed all-on-4 and an atrophic maxilla. So you can see this young man, this gentleman was only 40 years old. He unfortunately had 2 attempts at failed all-on-4s in the maxilla. He wanted a Hollywood smile, and look what he ended up with, wearing a denture at the age of 40. It's terrible. Nonetheless, he came to me, and at the time I did even though this is a very severely resorbed maxilla, I did the intramaxillary technique. And you have to use extremely angulated abutments for this. So we placed 4 zygomatic implants, loaded them immediately, You can see here that he had an overdenture in the mandible, and over the years he had more and more bone loss to the point where he was going to need an all-on-4 and the mandible as well. He didn't come to me for that. He went to Europe. It was going to cost him a lot less in the clinic. Unfortunately, it didn't work out for him, and he lost the all-on-4. The all-on-4 completely failed for him. And that's another thing with medical tourism. A lot of times, people that advocate medical tourism, it's great if you have appropriate follow-up. It's not that the surgeons in those clinics are not as good as you and I. It's just sometimes patients are lost to follow-up, and you have to be willing to go back and forth. If you're going all the way to Hungary or to Romania or Croatia for your dental implants, you better be prepared to go back and forth for follow-up. Nonetheless, his lower all-on-4 failed, and he became dental cripple again. Here I'm going to show you a case where I did a combination of pterygoid and zygomatic implants. Today's talk is mostly about zygomatics, but sometimes I go in there to place a quad zygoma, and I'm unable to place two zygomas because the zygoma is small. And this is a perfect case of that. So this gentleman had a somewhat of a wimpy zygomatic arch, so I couldn't place two zygomatic implants on each side. So here we're just doing a preoperative measure of the lower half of the face, the nasion to the tip of the chin, the pogonion, and that way I don't want to change. I don't want to change that. We don't want to change your face. I like to do a two separate incisions, one half versus the other. So I do a hemi-Lafort, but sparing the incisive papilla on either side. This is a retractor that I developed. It's an interesting story behind this. I got the idea from Professor Brandemark himself. I saw his retractor, and I liked the idea, so I went back to KLS Martin, and they designed a new retractor for me. And obviously, I don't know. At the time, they weren't willing to market it because there weren't many surgeons doing it. But nowadays, there's more people that are doing zygomatic implants. But here you see, I put the retractor up there. We do a big soft tissue dissection along the inferior funnel, lateral surfaces of the zygoma, and you have to be cautious. You don't want to get into the orbits, and you certainly don't want to get into the masseter muscles because you can get into some extensive bleeding there. And if you get into the infratemporal fossa, then bad things can happen there, infection, bleeding, and you try to avoid all that. Here you see at the tip of the retractor, there's a lip here. That lip is placed behind the zygomatic notch, so that way nothing slips out of your hand, your drill doesn't go into the skin, and more importantly, upwards toward the orbit. Then, following the zygomatic dissection, here you see I made a big 10 by 15 window, and meanwhile, I keep the Schneiderian membrane intact. So it's like a sinus lift. This is actually a lot easier than a sinus lift because a lot of times, you're basically trying to, I think the sinus membrane tends to be a little thicker further up, and you're avoiding, you're not placing a bone graft. So even if you get a small perforation, you're not worried about bone graft material getting into the sinus. You are avoiding that altogether anyhow. You're not doing bone grafting. This is a graftless solution. So then, we place implants. Here in this case, I did 2 anterior implants, 2 zygomatic implants, and 2 pterygoids. And we did an immediate hybrid temporary prosthesis. So this gentleman could have gone through block grafting and massive reconstruction of his maxilla, but he would not have had teeth right away. So in exchange, now he gets teeth, and he didn't have to go through a hip graft and big surgeries. Long term, obviously, we've had data that success rate is 95 to 97%. This gentleman does not smoke, not diabetic, no history of cancer, no bisphosphonate. So I'm pretty optimistic he's going to have these implants 20 to 30 years. But not all patients are like that. So this is how he looks immediate post-op, and then you see we took impressions for the finals. This is a verification jig, and we placed him in a beautiful final, and then I think here you see the final restoration. Now, with the traditional technique, you can see sometimes the implants are slightly palatal because that's how they emerge. So the thing about the traditional technique is that you get what we call a palatal emergence for these. But nonetheless, patient went from a denture to a beautiful fixed restoration. And this is your photograph showing the ideal positioning of the implants. Now, what about for people that I've had, and Dr. Carlos, this is actually a great case. I wanted to share this with you. This is a patient who went through an onlay bone graft and LaFord osteotomy to reconstruct his maxilla, but unfortunately, and he had a history of ectodermal dysplasia, the bone melted away. You could still see the plates in there from 20 years ago when he had block bone grafting. I wasn't going to remove them. So I just placed 2 zygomatic implants on each side, and he went from this sunken mid-face look to a beautiful appearance on the right side, where you see he's happy. He's got a beautiful restoration in there. So sometimes the bone grafting doesn't always work. And of course, we have patients that have been wearing a denture long term. So there's a patient that we did a quad zygoma on. This patient was wearing a denture for a long time. I was able to put in 1 anterior implant, and we get a nice result. Like I said, we have lots of patients that have zygomatic implants done elsewhere by someone who's not properly trained, and they fail. Here, a patient had 2 zygomatic implants placed a little too far anterior. As you can see, they're not engaging great cortical bone. They're very close to the orbital rim. And then 2 anterior implants that one of them broke off is in the patient's nose. So then I had to remove those and place 2 more zygomatic implants. There was nothing anteriorly that I could place, complete loss of bone. So, and this patient did well. So up to this point, if there's any questions, feel free to send me an email. This is my email, vbomfs@gmail.com, or feel free to send me an Instagram message at it's Broumand underscore oral surgery, and I'm happy to answer any questions. So then there's the extramaxillary technique, and these are some stock slides from Norris Medical. It's one of the companies that makes the implants for zygomatic extramaxillary technique, although there's a number of implant companies out there that now are making these. This is just the one that I've been using. So why the extramaxillary approach? Well, it's an easier technique, and there's less morbidity if you do this the right way. And same thing, there's no need for grafting here. The thing to keep in mind is when you use the extramaxillary technique, you're bypassing the maxillary sinus. Therefore, obviously, this attempt to avoid damage to the membrane, sometimes that happens. I've had some patients that have had zygomatic implants that later come back with severe sinus issues, and that's an issue for these patients. But here, your implant prosthetic platform, instead of being in a palatal position, ends up in a more buccal position. So that's something that's ideal, and therefore the restoration doesn't have to be so big like my previous patient had. And they make their abutments up to 60 degrees. But you can see here the difference with these implants. They have a smooth portion that's attached to this threaded portion. The smooth portion is about 30 millimeters long. That way it's laying outside the sinus and the maxilla, and you can put a membrane or the buccal fat pad over it. Then now, as opposed to an external hex granomark, you're looking at an internal hex connection, which is somewhat ideal as well. So is this better? In my hands, it has been. But like I said, every surgeon will make his own decision, and they're able to do these cases in a way which serves them and their patients best. This is the kit that they have, titanium grade 4. And as I mentioned, it's got a 2.4 millimeter internal connection, which is identical to the Zimmer platform. The implant's 4.2 millimeters. There's a certain drilling sequence. We're not going to go over the drilling sequence here today, but there's different drilling protocols for dense bone and not so dense bone. But just remember, the zygomatic bone is generally dense bone. So sometimes you have to keep in mind that you're going to be driving, even though this implant has a aggressive thread pitch. You can't really under drill these too much. But if you over prepare them, then you're going to get spinners. And remember, there are no rescue zygomatic implants. They all come in one side. So every case is different. Keep that in mind. Here you can see this implant has um, 3 different diameter drills and 2 different heights. So the first one is your um, thinner one. Here, I'll go back to that. Is your pilot drill. It's 2 millimeters at the tip. The second one is 2.8, and so is the third one at the tip. But then they get wider in the mid-body portion. So if you're prepare your first osteotomy and try to place the implant, and you're having to put too much pressure on there, then you go back and re-drill with the next drill. But I rarely have to go to this final drill. As you can see here, the drills are numbered 1, 2, 3. I never have to go to this third burr, hardly ever. But you create a slot in the sinus with these diamond burrs, and that way you avoid the sinus altogether. These are just different components of this. And so you have the 2 millimeter, 2.8, and 3.2 millimeter burrs. And like I said, I rarely use the third burr because I'm able to get good primary stability with just these first or second burr. And you have to have a combined 80 Newton centimeters on yours to be able to load these. But in general, that's never been an issue for me. So they have same array of multi-unit abutments that are used. I'm not going to go over all these. But the good news is here, now you have up to a 60-degree abutment that can be used for these cases. So what happens is basically now with using these longer abutments and angled abutments, you're able to get a better ideal position and an ideal platform. And then you can basically, once you place the implant, use these guide pins to determine what angle abutment you're going to use. There are similar systems out there, like I mentioned, that advocate the extra maxillary technique now. Nobel Biocare and Southern Implants. I used an implant system in Brazil, which I'll show, which is similar to Southern Implants. It had threads up top, which was really, really nice. This is the surgical zygomatic protocol. I'm not going to go over the protocol here, but let me go show a case here. So basically what happens is we place a groove in the zygoma, and then you push the sinus membrane out. And as a result of that, you're able to place an implant into the body of the zygoma without having to perforate the sinus mucosa. And here you're in a more ideal position. You don't have, I mean, there's still technique involved in using that diamond, but there's less chance of perforating the sinus. Here they're using some bone cement over the exposed threads. I don't do that. Obviously, there's no threads. It's just the body, the cylindrical body of the implant. What I do is I place the buccal fat pad. I'm going to show you a case or two. This is some of the courses that I've taught. This was in Miami. I was working on cadavers here and showing the docs how to place zygomatic implants. Here you see I have my retractor in hand. This is another course I did in Miami as well. Different date. This was a one-day course. Here's the retractor I was mentioning to you that I made. It's sold by Osteolife Biomedical. It's actually a pretty good, nifty tool if you're going to be doing these zygomatic implants. Now let's talk about some zygomatic implants with the extra maxillary technique. Once again, failed all on four. You see that a lot because I see a lot of failed all on fours in my practice. So here you have a young lady comes in her mid 40s, failed all on fours. She's wearing a denture. You go to sleep. So in my office, I either intubate these patients or now I do more and more of the open airway technique for these patients where I don't necessarily intubate them, but here you see a failed maxillary all on four. Implants are all gone. Bone is gone. I like I said, I save the incised papilla because I'm going to suture the buccal fat pad to that. Do my dissection on either side. Push the thick, tenacious mucosa out of the way because once you have a couple of implants that go in there and fail, you get scarred mucosa. Once we expose the zygoma, I put my retractor up there to the zygomatic notch, and we make a pilot drill there, and then use our diamond burr to make a window. into the zygomatic, I'm sorry, intrazygomatic window over the lateral portion of the maxilla without perforating the sinus mucosa, and then we place two implants on either side. Obviously, in this case, what I like to do is I use these, I cheat a little bit. I use these cottonoids to protect the sinus mucosa while I'm doing my osteotomy, placing the implants, and it's a nice dry field. You can see the buccal fat pad lurking behind here, where I'm going to use it to cover the threads of the implants. So here you see my burr catching that cottonoid. It's not catching the sinus mucosa. So it's not really a problem for me here. Here, these dedicated burrs also have the measurements on them, so it tells you how deep you're going and how much, where your implants are going to end up depth-wise. These are the implants being placed. You can see the aggressive threads, even from here. You can place them by hand or with a handpiece. I place them by hand. Actually, in this case, what's interesting is this is one of my first cases with Morris. I underprepared the first osteotomy, so I felt like the zygoma cracked a little bit. So I went back and redirected it. Here you can see a little crack in the implant. So I took it out, and here you see I redirected it superiorly because I underprepared the osteotomy, and as a result, um, you can put in a lot of power, and you can actually break things if you're not cautious. So then we place a second implant. So in this case, you can see here we have two implants that are crossing each other. So when you place these zygomatic implants, sometimes they're parallel or they're crossing. The most important thing is the tip of the implants are not touching. I use a clear surgical guide. I don't do guided zygomatic surgery. Some people do. I've done so many of these that I think I'm aware of the anatomy, but nonetheless, I never get comfortable with this. I always check myself over and over and over during the surgery and make sure my prosthetic platform ends up within this clear channel in here, and that way I am cautious as to not do anything that I'm going to regret later. We do the same thing on the opposite side, repeat the same exact procedure. Here you see two distinct channels here, right? So I have two distinct channels. You can see the two distinct channels that are being placed, and you have two parallel implants placed next to each other. So here you see the quad zygoma completed. You have two implants that are parallel and two that are crossing. Nothing wrong with either technique. It's just a matter of having implants in an ideal prosthetic position there, right? So as you can see here, prosthetically, they're both ideal. It comes out in a more buccal position, right? So actually what happens here is you are um, placing these implants extramaxillary and they're coming out in a more buccal position. So it's nice because now you're not worried about the implants coming out in a palatal position. It's actually very nice. So I'm excited that I was able to do this service for this patient, and we provided her with a valuable service because she had a failed dental implant. And of course, when this happens, you don't get an easy scenario. So here you see the retractor, tips of the implants are in the ideal position. Then we put in our multi-unit abutments. As I said, with this system, you're able to get multi-units up to 40, up to 60 degrees, right? So as a result, what happens is you have even if the implant is extremely angled, you have an implant that is being placed at any angulation. The angulation can be corrected with a angled abutment. So once the implants are in the proper position, the abutments are placed, and then your lab tech goes to work. I keep on checking myself with the surgical guide to make sure that I'm in the ideal position. You can always change the abutments now. It becomes a lot harder to change those later. then we go ahead and check our bite, check everything before we deliver the temporary here. This is no different than converting a regular hybrid, you guys. It's no different. Then we do a pickup there so we can make a master cast later for the final. My lab tech goes to work to convert this, and we do a nice conversion. On one side, I did bone grafting over the area where I thought I had fractured that zygoma. And here you see the buccal fat pad being sutured over those exposed cylinders. So one of the things about the extramaxillary technique is that when you do the extramaxillary technique, you can develop some sensitivity where patients can feel cylinders sometimes, and as a result, when they feel the cylinders, it can become uncomfortable for them. So what we do is I take the buccal fat pad and bring it all the way to the midline, which is why I save that incisive papilla, and as a result of that, the patients won't feel. The buccal fat pad will possibly atrophy a little bit. You see a thick, tenacious buccal fat pad that's brought over there, and patient doesn't feel it. This is our temporary there. You can see she has such a narrow V-shaped maxilla. So this was a really, really difficult case. However, we end up with a great result for this patient. So you go from something like left, where you have a completely atrophic maxilla that patient has really no hope. By the time she came to me, she thought there was no hope, to a nice, nice result. And this is a temporary, and then patient 6 months later gets a final. Photos of the final yet because she still doesn't have them. She's so happy with that temp, she hasn't come back. This is one of the courses I did in Brazil. So, Dr. Carlos, I'm not sure if you've seen this system in Brazil before. It's very similar to southern implants. It's actually a pretty unique system. We had 4 surgeons, general dentists, periodontist there in the course. It was great. We had a great hands-on session here on the left. You see that we worked on some skull bones, and the following day we worked on patients. This is our setup in Brazil. We worked at the San Rafael Surgical Center in Sao Paulo, and everything's done correctly. Everything's done in a very nice way. I love the surgery center. I love Sao Paulo. Can't wait to go back. It was really a great setup for us. Here's one of the courses I did in Miami there. You see us working on cadavers here. And so this was sponsored by Norse Medical. I work with, like I said, I work with multiple one-time companies, but there's multiple products out there. This is a lecture we did there, so we do a hands-on session here. You see the cadaver heads. We're going to be using cadaver heads for this course. But this was another course that was done in Miami. This is my course down in Brazil. And you can see these implants are pretty unique. I want to show you here because they have a threaded portion at the apex, and then they have more threads up top. So that way, with these, you're also engaging that palatal bone, if any. Because sometimes what happens, there's no palatal bone, and as a result, you don't need any screws up there. But in this case, we had a very nice thick portion of palatal bone. So this implant system was ideal for use in this system that we used in Brazil. Because in Brazil, we could not take any implants from the company. It was kind of an interesting setup. But you can see here my retractor sitting up there in the zygomatic notch. We placed the implant here. You can see the screwdrivers placed. So that way, we're trying to make sure that the restorative screw comes out in an ideal position. You see our guys, Dr. Rossi and I were training these 2 oral surgeons there. This is my colleague, Dr. Renato Rossi. He's an oral surgeon in Sao Paulo dental school, so he was very, very gracious. He's a great host, so we did this there together. Like I said, I encourage you to attend zygomatic courses that are taught by experts in the field. I'm not saying I'm an expert, but I've done so many of these. But you want to make sure that you learn these courses, learn these surgical cases the proper way. Do it on a cadaver, then go watch one, then go watch another one before you attempt to do these. But it's a great service to these patients. So I'm going to show you another case here. A patient had an all-on-4, and we did zygomatic implants and um, lower all-on-4. So this is one of those rare cases where I get to do an all-on-4. But you can see here, very severely atrophic maxilla and horrible dentition on the bottom. This patient had terrible dentistry when she was younger. Unfortunately, it happens. I don't judge any of my patients, but what we're able to do is change your life. In just a matter of hours. We took out all those teeth, placed 4 zygomatic implants. Here you can see that I placed them parallel to each other. I spared that incisive pupilla so I can bring the buccal fat pad over. Now, as opposed to the previous case I showed you, this is a more ideal position of the implants, but we have to take this patient from that horrible looking partial to a beautiful upper and lower on the floor. The patient is very pleased, ideal position. You can see in the lateral ceph portion as well. This patient is quite pleased with the result. And they didn't have to go through an extensive grafting, and this cost them a fraction of what it would have cost to go through hip grafts to the maxilla and obviously waiting period of not having teeth. Here's another case. Patient came to see me. Look at this flat maxilla. She had a couple of failed attempts, had an all-on-4, and we did same thing. 2 zygomatic implants on each side, ideal positioning. Now, what about complications? Well, complications do occur with any kind of dental implants, right? Now, in this case, how do we deal with it? This is a cutaneous fistula. This happens. So this is one of my own cases from years ago where I did um, the traditional intra sinus technique, and the tips of the implants, which are nice and round, are sticking out the lateral body of the zygoma. This patient comes back 6 to 7 years after surgery, after he had lost a lot of weight, his face was sunken in, and he started having this cutaneous fistula here. So I had to go back and do apicoectomies on these implants, rounded off the ends of those implants, and you can see how he healed really well. There's hardly any scar there on the side of the face, but I went back and I opened these up and did a apicoectomy. This is another patient that was referred to me. He had a maxillary tumor resected. He had zygomatic implants placed for immediate reconstruction. This is one of those things that I don't do. He had a big odontogenic myxoma. It was removed. They did zygomatic implants in the hospital. The next day, they placed a big restoration, and he had a massive oriental fistula. This is very difficult to treat. Other than I have not treated him yet because I've told him we've got to take these implants out, and he's going to have some kind of defect. No matter what we do, it's a bony or soft tissue defect. This is another patient that was referred to me by someone who didn't have a lot of experience with zygomatic implants. On one side, he developed a massive oriental fistula, and they tried to close it 5 times with a buccal fat pad. But once again, if you don't have a lot of experience with a buccal fat pad closure, you are not going to be able to do a good job. So in this case, I did a buccal fat pad procedure, closed it primarily, and the hole remained closed. However, the zygoma was completely destroyed on that patient. This is another case that I saw where you can see on the left side, one of the implants penetrated the orbital floor, and that's really not good at all. Luckily for this patient, they were not blind. The implant had entered the floor of the orbit and was laying underneath the inferior rectus, but they didn't have any orbital issues. So this is some of the other courses that I do. I was supposed to lecture at the Western Regional Dental meeting this year in Phoenix, but of course it just got canceled because of COVID. I'm hoping that next year, it looks like June of 2021, we're going to be lecturing at the Florida Dental Convention at the annual FNDC. So I'm looking forward to doing that. I encourage you, like I said, if you're interested in zygomatic implants, attend some of these lectures, see if this is something you want to do, or sign up for one of the courses either by myself or other people. We have 3 to 4 courses a year in my office or in Florida, or there's other surgeons that are teaching this. Now, luckily, people don't have to go overseas anymore. I'm able to do these in my office in Phoenix, because in Phoenix, as long as you're a licensed dentist, somewhere in the country, in Arizona, you can get a 1-week license here, as long as the patient is not paying for the services and the course tuition is paying for it. So it's nice because, as much as I love going to Brazil, I don't have to go to Brazil to teach the courses. Now I can just go to Brazil for vacationing, and do the courses here, because it is kind of a far flight. But at least I got to take my family. And I think with that, if there's any other questions, like I said, feel free to send me an email, or feel free to send me an Instagram message. I'm happy to answer any questions that anyone will have. And I think, so that's the end of my presentation. Let me go back to this other screen, or we can go back to the other screen, I think. Let me see where we are. Dr. Carlos, can you see me, or there we are? All right. Can you hear me?
Yeah,
Oh,
thank you. Yeah, I can hear you. Thank you so much for your
oh,
presentation. Very, it was it was an
thank you for
excellent
having me.
presentation, and I have some questions. I think that we don't have question from our audience, but I like it when you said that you prefer the buccal fat pad instead bone graft in the buccal wall. I think that you can reduce some complications with these
That is
procedures.
correct.
Am I
Yes.
right?
So, obviously, when the reason that we bring the buccal fat pad or doing any graft, so I did grafting on the one side for that patient because I felt like the zygomatic arch, there was a little green stick fracture underneath it. So I grafted all the way around it and over it, so there was be less of a chance of a problem there long term. But also, I bring the buccal fat pad over because that way they don't feel the cylinders in their cheek. So,
Yeah,
and ideally, what you want to do is have the implants flush with the lateral maxillary wall, the antral wall, so that way you're not having them feel those completely. But nonetheless, I think what happens is, if that happens, then patients complain because the only thing they know is that they feel something in their cheek, right? So what you want to make sure is that you have something covering those cylinders.
perfect. I hope to attend one of your course after COVID-19 period for
Sure, I'd love
sure.
to have you there, either here or in Brazil.
Yeah, maybe here it's easier.
Sure.
Nowadays, we have many options to rehabilitate our patients, right? And the Zygomatic implants are one of that for sure. Also, with the advance of technology, the question about the the titanium treatment, and we can prototype right nowadays. We can prototype the atrophic maxilla and prepare such as subperiosteal implants. What do you think about those implants, subperiosteal implants?
That's actually a great question. So, the subperiosteal implants, I've taken out many of them that got infected. The
Yeah, me
wear
too.
pattern of the maxilla and mandible are different, but the wear pattern of the mandible is such that a lot of times you'll have great stability initially with these subperiosteal implants, but later on you get uneven wear and then they become loose. So right now there's a company out of Canada that is making some new kind of subperiosteal implant. It's called Panthera. I don't know if you're familiar with those. And it's titanium subperiosteal implant, and that's
Yeah,
almost a
that's what
great,
I mean.
yeah, the great discussion for a separate. So I've had a couple of failed mandibular all on fours, and the referring doc was asking if I would consider doing Panthera, and I said, I haven't done any, but my
Hmm.
experience with any kind of subperiosteal hasn't been good. And he said, well, the ones I've seen have always survived and they've done great. So my answer was, then you haven't seen enough, because I've seen so many that failed that I'm almost afraid to
Yeah, yeah,
try subperiosteals. And I'm not saying I never will, but they take this new CAD CAM subperiosteal and they
yeah. That's
adapt the
yeah.
titanium
That's
bar that you
that's the
screw
idea.
in. Yeah, so you screw it into the mandible, and then they have the fixture heads coming out, and you're going to do a restoration on top. I'd like to try one, but I would have to tell the patient if I ever try one, and I have a patient now came to me for a subperiosteal, I was
Mm-hmm.
going to tell them I don't know if this is something I would trust because there's only one doctor in Canada who has done a lot of them, and now he's unfortunately ill and not doing anymore. But there's a doctor that published the data, and if you do a Medline search, there's really not a lot of these subperiosteals out there. So I'm not so convinced
Yeah.
that I'm willing to try them. What is your experience with them?
Uh, uh, just removing,
Yeah, I
just
mean,
removing Russia because I was thinking about maybe with the as you told us, maybe with the technology about the prototype of the maxilla with the technology of CAD/CAM, we can produce something like titanium with a very good surface, and maybe we can hold it with mini screws in the maxilla. I don't know. Maybe it's only an idea for the future.
right, and I think that's what they've done with this implant system in Canada. And I want to try it before I pass judgment, but I'm reluctant because of everything that I've seen. But people have tried this, the blade implant, subperiosteal. I mean, you're not old enough to remember, but there was the transmandibular staple implants. Those obviously they
Yeah,
were around before my time, but I've taken a bunch of them out. And so that kind of is a thought that is somewhat I'm averse to. I'm afraid of trying something that might fail. I don't like to try anything that's going to fail, but I'm willing to try something if they show me scientific data that it works. So right now I'm actually maybe working on it. So maybe next time we'll talk more about subperiosteals. I've had a couple of patients that I was willing to try it, but I wasn't willing to take the chance on their health. So I might try it. We'll see. We'll have to wait and see.
perfect, perfect. Uh, and what do you think about the computer guide approach for placement of zygomatic implants? Do you have some experience with that?
Well, it's interesting because I actually myself have not done any guided zygomatic implants. So years ago, when I first started zygomatic implants, I approached my friend Dr. Tom Balshi. He's a very well-known prosthodontist. He was in Pennsylvania. Now he's teaching at Nova Southeastern University. And he said, well, we're working on it. It could become something that's FDA approved. And of course, now multiple companies have come out with it. Norris Medical has the Easy Goma, and it seems to be great. I know a lot of my colleagues are using it, and it works well. And I have not done it only because of the cost factor. Because when you do the guided zygomas, it adds $5,000 just
Yeah,
cost to the case, and it's already hard for some patients. I have, for example, my patient that just came back from Cancun, he invested $30,000 in his mouth that is gone. He can't get it back. Or the other patient that went to Romania spent um, well, only 12,000 euros, but it was enough and it failed. There's no recourse. They can't get their money back. It's hard. So now it costs me more to do it right the second time, although with this patient, I would consider doing it because I looked at a CT scan. I would probably do the easy goma or the guided cases where the zygoma is somewhat smaller and it makes the case more unpredictable. But I freehand almost every zygomatic case. I mean, I freehand every one, but I do
yeah,
plan it ahead of time on my software. So I go to my Anatomize software. I plan it to make sure it's possible to place two implants with the tips at least 3 millimeters apart. I avoid the infraorbital rim by 3 millimeters, and I obviously avoid the infratemporal fossa completely. I don't want to fall into hitting the masseter or putting the implant where you're going to get a bleeder. And that way, I avoid the need for the guide case. But I would encourage the younger surgeons who haven't done any, or if you're just getting into zygomatic implants, definitely try the guided cases because they're work.
Mhm.
I just haven't done guided cases because it's a cost factor. Because the surgery is already,
I see.
I spoke with my friend Dr. Edmund Bedrosian, who's one of the pioneers in the U.S. on zygomatic implants, and actually he doesn't agree with the extramaxillary technique a lot, and he's made that clear. Dr. Paulo Malo, who's in Lisbon, he is a big advocate of the extramaxillary technique. So there's a lot of agreement and disagreement amongst the experts in the field. But I spoke with him once with Dr. Bedrosian. He said, you can't charge enough for a zygomatic implant because it's such an aggravation sometimes because these patients are difficult patients. I recently had a case where I did 4 zygomatic implants on a lady who had multiple failed all-on-4s. And I saw some red
Mhm.
flags, but I didn't take heed. I should have been cautious. So she had tried to commit suicide twice before because she had lost her teeth and she had no self-confidence. Well, that's not the kind of patient you really want in your practice. But I felt so bad, I thought I could help her. Well, we did the
Mhm.
surgery, we did 4 zygomatics, everything was beautiful, went perfect. And she didn't like the way the temporary teeth looked. And I showed her a picture with her denture. I said, "This is you, how you were with your denture. It was awful looking." I said, "These are temporary teeth. It's just a 4 month period. You have to wait till you get finals, and you can at that point get, you know, zirconia. You can get blue. You can get purple. Whatever color teeth you want. You can do what you want, but just wait till this thing is fully healed." Well, she took a Dremel and a nail file and shaved the teeth down herself and caused failure
Mhm.
of one of the implants and of course the restoration. I mean, that's the kind of patient that you don't want in your practice. So a lot of these patients, of course, by the time they get to this stage, they have been traumatized. It's almost like a PTSD, like a post-traumatic stress disorder, but it's from dental implants. And I should, when someone tells you I try to commit suicide because I don't have teeth, you have to think about that. Do I want to work on this patient?
Yeah.
Yeah. So, like I said, I mean, some cases like that, I mean, you may not even want to do, but if that answers your question, I haven't done guided cases, but for cases like this, I think it's a good option.
Perfect. Perfect. I see.
Thank you.
Um, Thank you so much for your presence today with us. I'd like not only to thank you for your presence now, but in name of the peer-to-peer, in the name of Global Implantology Institute, I'd like to thank you for your amazing presentation. And I hope to see you soon after this COVID time for sure.
Me too. Thank you. Thank you. Come visit us in Arizona. Um, it's a little warmer than California, but come visit.
That will be a great pleasure for
Yeah.
sure.
Thank you, everyone,
Thank you.
for having me. Thanks for everyone who attended and for the great questions.
Thank you all. Thank you for your time. And I hope to see you soon.
You bet.
Bye.
Thanks. Bye bye now.